This is my own experience of patients that I've treated with DAAs since we have them available. Just to have an idea what's happened in Portugal, until before 2015, we're not able to treat co-infected people with DAAs. Some centers, very exceptional, used likely the boceprevir and tenofovir. In March 2015, there was, as you all know, an agreement between the Ministry of Health and Gilead, so we were able to have Arvoni available at the first time for all patients if you wanted to. So in March 2015, I treated my first patient with new DAAs, a very difficult one with cryoglobulinemia and fungemia, a very difficult one that recovered completely. And since then, we have no restrictions in the prescribing. There are only a very few hospitals that have limitations and can treat only F3, F4, no limitations for the others. And more recently report, as you can see from March, from 4th May, at the moment, in the platform, because these are not real data, in the platform, about 18,000 patients initiated therapy, and the results that we have at the moment regards 10,000, but they are not really numbers because most of the clinicians don't have time to actualize the platform. So, but regarding the results we have at the moment, the SVR is 96%. So we have all the medications, the 8 schedules, 8 regimens we have, and with no restrictions. And when I made this retrospective analysis of my own patients, I just wanted to figure out if HIV is a burden or not, because we already know that the virus does not affect the therapy and vice versa. The only thing I've noticed in my patients, about 4 or 5 patients had an elevation of HIV viremia during treatment at the end or after, but soon they return to undetectable. Regarding ART, it's easily to handle, it's adjustable, so I have only 2 or 3 patients that had complications at the beginning. They were very advanced patients with very advanced disease, so I have complications in F4 patients under protease inhibitors when I have to treat them with soft lead. So in those patients, at the beginning, I changed all them for raltegravir plus the backbone. Regarding the co-medications, there's no more a problem because we know that in Portugal, HIV population has an average of 49, 50 years. So the mono-infected population also have comorbidity. So most of our co-infected with that age takes or have diabetes, hypertension, and so on. So we can easily handle the potential DDIs. The question is the adherence and what's happened post-SVR. Regarding adherence, we have lots of papers, as all you know, about opioid substitution therapy, and we know that even person under methadone or other drugs result to have success in the HIV treatment. And there are anyway any particular social problems that our co-infected have that mono-infected doesn't have. Namely, they are more people without social help, more times incarcerated and so on, and that was this that I tried to find out in my retrospective analysis. So I characterized both population, mono and co-infected, and I looked for viral aspects and host factors as also as social features, as I mentioned before, incarceration or opioid substitution therapy, and I analyzed these two populations since March 2015 until February this year. So I initiate 100 in chronic hepatitis treatment. I can say in my unit we initiate about 500 treatments. These 180 correspond to 174 patients with an average age at 48 years, predominantly male, and about 2/3 naive, so they didn't make any previous HIV treatment. When looking to genotypes, they were, as you can see on the left, 68 genotype 1, and then followed, as usual in Portugal, by genotype 3, 18%, and genotype 4, 12%. I mentioned that in patients that are already treated with other PEG-RIBA or PIs of first generation, they are almost genotype 1, more than 70%. The co-infected population represents 42%. And when looking to the degree of fibrosis, I don't know where the light is, but okay. Looking for the degree of fibrosis, as you can see, the advanced fibrosis means F3 and F4 represents 42%. And looking to the social features, as I mentioned, they were almost 10% of prisoners, but if you look to HIV positive or HIV negative population, there was a big difference, namely 16% of HIV positive and 5% of HIV negative, and the same regarding the opioid substitution therapy, more HIV positive persons use this medication. When looking to treatments that we've done, it's not surprising to see that soft lead represents the majority of patients, because at the beginning we have that drug available for all patients, including for all genotypes. And I have to admit, I treated 1 or 2, fortunately, with soft lead, with genotype 3, and later on soft and RIBA, and no more. Since I have the opportunity to treat genotype 3 with the soft declatazivir, it was my choice, of course. And we have also soft declatazivir, soft ribavirin for those with genotype 3, 3D in patients with renal insufficiency, and more recently, because there were recently approval in our country, Hepatitis and Softvel. And the results are here. At that time that I analyzed this sample, I was results in 156 patients. And as you can see, 8 patients had a relapse, and they were distributed 5 by genotype 1, 2, and 3. And the other 6, 3 of them died, and 3 were lost for follow-up. I can see that the 3 that I've died, 2 related liver complications, and 1 that not related with this. And 3 patients have hepatocellular carcinoma, all of them HIV. 1 is dead, and 1 was referred for unit transplant, and fortunately for the 3rd patient visited me the day before I came, completely recovered from hepatic transplant. So the sustained virological response was represented on those 2 charts, namely when in an ETT analysis the results were 91%, but if you look to PP analysis the results were almost 95%. So results very similar to other cohorts in every world. So there were 6 cases of reinfection. This is what was surprising, because and sorry, just to go back a little bit, the SVR was 94% or 95% all, but if we look to HIV population, all of my 74 HIV patients have a complete SVR, so they cured. There were 6 cases of reinfection, but all in HIV population. It represents 1.1%. All of them drug users. We have a few, contrary of other European countries, we have only a few, at least in the center of Portugal. It's not happening the same in Lisbon or in Oporto, where MSM begins to arise. In our center, in the center of Portugal, there are mainly EUs. And at the moment, 6 patients of those that relapsed were retreated, all with those regimens, as you can see, soft plus declatazivir, plus Hepatitis, plus 3D, or plus Val. And at the moment, 3 of them has recovered, has cured, have SVR. 2 are still on treatment, and 1 patient failed again. This patient did 2 treatments with PEG and ribavirin. He's a genotype 3. Then he makes soft lead riba 24 weeks at the beginning, of course. Then he failed. Then he made soft declatazivir ribavirin 24 weeks, and he failed again. And it starts 2-3 days ago, last week, the combination soft Valvox. So these are the details if you just want to see of the failures. It has no special feature. They belong to several genotypes, several degrees or stages of fibrosis, and different regimens. And as a conclusion, we can see this chart over there represents the difference between HIV and HIV positive and negative. So the SVR was 100% in HIV population. The hepatocellular carcinoma occurs only in 3 patients monoinfected. The incarceration is more representative in HIV population as also as the opioid substitution therapy, and reinfection occurs only in co-infected. So I think according to, once again, HIV is no more a burden in the success of HIV treatment, and all of us should be aware of the question of reinfection, mainly as it was shown this morning in some papers. There are really a risk of reinfection, mainly in persons that have risk behaviors, but in our center, mainly EJUS and not MSM. Thank you.
Thank you very much. That was great. So since there's such a relatively high reinfection rate, and you said these were all IV drug users, but you have a relatively low substitution rate, right? I mean, were these reinfections in patients who were in an opioid substitution program, or were they not in an opioid substitution?
Oh, I'm not sorry. I didn't know, but I remember 2 of them. I'm sure, but the others I'm not sure at the moment. Yes, because
you wonder. The substitution rates are relatively low, and it might be that there just needs to be a thinking of how can you get better access to opioid substitution overall. No? Corinne, and then Juan.
Kun.
Yeah.
Regarding the ARVs, regarding the antiretroviral therapy used in your patients, did you have problems to adapt ARVs, antiretroviral therapy, in your HIV patients?
The HIV therapy?
Yes, the 76 patients that you have treated?
Oh, sorry, maybe they are quite
No, just, did you have problems to adapt, to choose the
HIV regimen?
HIV regimen?
No,
exactly.
no.
Just,
yeah.
because, you know, with Velpatasvir, for example, there are more drug-drug interactions than with Ledipasvir,
Yeah.
and even with the new combinations, Grazoprevir, Basvir, even more. So,
No.
did you, because that's your personal experience?
Regarding the Clatosvir, I just changed from PI.
Not the Clatosvir, but
sorry,
the other drugs.
The other. No,
Velpatasvir, etc.
No, because fortunately we have 8 regimens for HIV, so we can adjust easily. And as we know that integrase inhibitors has no problem, so it was not difficult to adapt HIV medication to HIV regimens. No, fortunately not.
Juan?
Cristina, congratulations for your presentation. There are several cohorts where the rates of SVR in HIV co-infected patients was lower. For instance, our cohort, the Madrid cohort, even in the GECKO cohort, the rates of SVR was lower in patients with lower CD4 cell count. Do you have an explanation for these discordant results?
I don't have that data regarding CD4, but I can, because I know all of these, they are my patients for many years. They are all controlled. I can't say to you at the moment what's the mean level of CD4, but regarding HIV, they were all suppressed, I'm sure of that. But I cannot say that maybe the next one is going to fail. So it happens in this amount of patients, every 74 HIV didn't fail. But I can assure you that HIV was completely controlled. But otherwise, if they fail or something, I don't initiate therapy because I'm afraid they lose the next appointment for HIV and for HEV, and we all have to pay these treatments. So HIV, I didn't understand if I understood correctly what you asked, if it is this.
Yeah, so I think Juan raised an important point. So when you look at different HIV, HCV cohorts, there are some who, although everyone sees great response rates, I think we're all in line with that, some show a 2% or a little lower cure rate in patients with HIV, and particularly in those who have low CD4 counts. And so the question is, why do we see differences between different cohorts? Some saying there's no difference, and some saying there's a little lower SVR, particularly in patients with low CD4 count. And I think one way to see that is that, in particular in the GECKO cohort, you only see a lower response because you also then see a much higher cirrhosis rate, because low CD4 count is the driver of cirrhosis, and so probably more advanced fibrosis comes with lower SVR, and that's true for everyone. But in the Spanish data from Madrid, where they only looked at one regimen and very well matched, still was a little bit lower response rate overall, which was not explained only by the CD4 count. So that is, I think, an ongoing discussion. Is there a little bit of a difference, yes or no?
Just to I remember the first one that relapsed, that had the reinfection, was an F4 with 180 CD4 cell. For example, but I don't remember the others. I didn't check for that, sorry, no.
Dr. Machante.
An indirect way to look that maybe something is happened is that some studies, 2 studies from Spain, have demonstrated that liver stiffness before treatment among those with cirrhosis can predict the SVR rate. And we all know that co-infected patients with cirrhosis tend to have higher levels of liver stiffness. So maybe something is happening in a subgroup of patients.
And I can tell you also that these patients, co-infected population is it's no difference, but they're little younger than the mono-infected. The mono-infected people were my patients for many years, and they didn't answer they didn't have achieved SVR with other treatments. And the stage of fibrosis, curiously, it's a little bit low than the mono-infected, but it happens in this group.
Yeah.
Does microphone 1 have a...
Regarding to HCV reinfection, what is the optimal time to repeat the HCV PCR in people who inject drug in active consume, thinking in these people who could transmit it to other person HCV infections?
It's a very good question. Usually I perform this way. I do the RNA after 12 weeks, 24 weeks, and at 1 year. And if it is an HIV patient, it keeps under my care. So it's every time I notice an LT elevated or something, I do the RNA. Or if this patient has a behavior risk, if it is a MSM, or because now are becoming to arise many young MSM, but not infected with HIV. But if he's a drug user, we should repeat at least once a year. In the mono-infected patients, it's more difficult. I keep them because due to a trial, I create a bias, so I keep them 3 years. So I have the opportunity during 3 years to check if they were reinfected. But after that, I don't know. But we just inform the GP that they have to care. They have to look about that, and if there is a raise in LT, just check or send it again.
And does the government pay for all the diagnostics? I'm thinking about Georgia.
Sorry?
Does the government pay?
No.
So the patient pays?
Only if it is HIV. If it is an HIV positive, you have a special, I don't know, budget, yes. And they don't pay neither treatments or diagnostic tests. But for a mono-infected patient that has no other problem, oncologic or so on, they have to pay, yeah.
Very much.
Thank you very much.